Hello, everyone, and welcome to today's webinar, Optimizing Mother's Own Milk Provision in the First 2 Weeks and Its Economic Benefits in the Neonatal Intensive Care Unit with Dr. Tricia Johnson and Dr. Leslie Parker. We are thrilled to have you join us. Throughout the presentation, you can submit your text questions to our presenters by typing them in the Questions app. Feel free to send in your questions anytime. We will collect them and address them during the Q&A session at the end of today's presentation. To maximize your webinar experience, you can participate using the apps during our webinar today, including handouts, chat, and polls. You can access the apps at the bottom right of the webinar window. Under the Handouts app, you can find the certificate of attendance for the webinar, including your CE credit, and the PDF handout of the webinar presentation. Please be sure to download these during the event. If you experience any technical issues, just click on the Help button on the lower left of the webinar window. Today's webinar is being recorded. After the event, you will receive a follow-up email with a link to view the recording. Without further ado, I would now like to introduce today's speakers. Leslie is the Associate Dean for Research and a professor in the College of Nursing and an adjunct professor in the College of Medicine at the University of Florida. She has had an active practice as a neonatal nurse practitioner for the last 30 years, where she cares for critically ill infants and their families. Leslie's research has been funded by the National Institute of Health and the Gerber Foundation and focuses on optimal delivery of nutrition to critically ill infants and increasing infant consumption of mother's own milk by improving lactation success in their mothers. Tricia is a professor of economics in the Department of Health Systems Management at Rush University and one of the few human milk economists in the world with a program of research that intersects human milk provision, economic outcomes, and policy for at-risk infants. She co-leads 2 NIH-funded studies examining the effectiveness and cost-effectiveness of an economic intervention to mitigate barriers to mother's own milk provision for very preterm infants. Her work also investigates the economic implications of secretory activation and the role of paid and unpaid work in mothers' decision about providing mom's own milk for preterm infants. And now I'd like to turn it over to Leslie to begin.
Thank you very much, Jessica, and thank you everyone for joining us today to be able to share our work that we've been doing recently. I also wanted to thank Medela for asking us here to be able to share our work, and also for Medela for supporting the development and testing of My Pumping Pathways. This is an evidence-based, standardized, and personalized approach to breast pump use. These are my disclosures. So we all know that mother's own milk is best for all infants. It's best for those that are term and are breastfeeding, and it's also best for those that are born critically ill and premature. We know that mother's own milk reduces complications in preterm infants. And in the neonatal intensive care unit, we consider mother's own milk to be a medication, and we treat it as a medication. And we also communicate to families, to parents, to care providers that it is a medicine and that it's so important in improving the health of our preterm and critically ill infants. It's also important for mothers. Not only does it decrease complications in mother, it also helps them to feel like they're providing some type of mothering to their infant. In the NICU, we sometimes have to take away many of those mothering activities that mothers consider it to be a normal part of caring for their infant. They can't feed their infant. They can't bathe their infant. They can't take their baby out of the crib. And sometimes the only thing that they can do for their baby is provide their own mother's milk. And in fact, they feel very powerful when they do this. Some mothers state, I felt like I was helping him get healthy. So we know that mother's own milk significantly decreases complications of prematurity. We know it decreases the risk of bronchopulmonary dysplasia, which is a form of chronic lung disease that increases morbidity and mortality in preterm infants. It also decreases the risk of necrotizing enterocolitis, a serious and life-threatening complication that causes potentially inflammation and sometimes even perforation of the intestines. It decreases the risk of retinopathy of prematurity, which is a significant cause of visual issues in preterm infants. And it also decreases the risk of infection, including sepsis. And it decreases these complications in a dose-dependent manner. So the more mother's own milk that infants consume, the less complications they are at risk for. And even doses as small as 10 cc's per kilo per day can help to decrease complications. In addition, it decreases the risk of developmental delay. Tricia, if you could go back one. Developmental delays decreases the risk of rehospitalization after discharge from the NICU. It reduces the risk of feeding intolerance and cost. But there's significant barriers to consumption of mother's own milk. And three that I believe are the most important are a delayed secretory activation, suboptimal pumped mother's own milk volume, and a shortened duration. We know that mothers in the intensive care unit have a delayed secretory activation. For mothers that are breastfeeding term healthy infants, secretory activation, or in other words, lactogenesis stage 2, or when the mother's milk comes in, usually occurs before 72 hours postpartum. But in those mothers that are pump dependent, whose infants are in the intensive care unit, secretory activation doesn't generally occur until about 5 or 5.5 days after delivery. So extended period of time after the baby is delivered. And we know the longer it takes for secretory activation to occur, or if it never occurs, the chances of mothers providing sufficient quantities of breast milk through to infant discharge is significantly lower. We also know that mothers often struggle to produce enough mother's own milk to provide exclusive mother's own milk feeding until infant discharge. And this is probably the most common reason that mothers stop pumping for their infants in the intensive care unit. We also know that mothers of infants in the intensive care unit have a shortened duration. And in fact, very few, less than 50%, will be providing their mother's own milk to their infant at NICU discharge. And so that makes it very unlikely for them to be producing and providing mother's own milk to their infants at the recommended 12 months postpartum. And these mothers, there's a lot of different risk factors why they have such difficulty producing and providing mother's own milk to their infant through to NICU discharge. They have a significant risk of comorbidities. So oftentimes these mothers are obese or overweight. They may have diabetes, and they may also have preeclampsia. And all of these are known to reduce the lactation outcomes, the lactation success in mothers of infants in the NICU. There's also a high rate of C-section. They may have immature mammary development, high maternal stress, maternal infant separation. So we really have to focus on those things that are modifiable. And what we generally consider modifiable are pumping behaviors. So one of the things that we really have done a lot of research on is pumping soon after delivery and pumping frequently in those first several days after delivery. And there's been a number of publications that have supported mothers that pump early postpartum and pump often are more successful in their lactation. And in fact, in the next slide, we can see that this goes on, and there's many, many different publications that support this. However, there's not as many publications looking at how do we optimize pumping behavior. So just because a mom pumps early and pumps frequently doesn't mean that she's pumping optimally. And so in order to optimize pumping behaviors, pumping needs to be effective, which means that the mother needs to be able to get as much milk as possible out of her breasts. It needs to be efficient, so the mother needs to get that milk out in a short period of time. And pumping also needs to be comfortable and convenient. And this is kind of difficult. And so we don't always think of this as being intuitive. So this has to be something that we specifically teach the mother, educate the mother, and we need to do that on a consistent basis. And it's not necessarily something that all lactation consultants or all healthcare providers may know. They may not have all of this within their realm of practice. So what we decided is that pumping behaviors need to be optimized, and they need to be personalized for each mother, and they need to be standardized. And so why is standardization so important? It's important so that mothers get the same education and the same optimization to the same level. Not only will that improve our outcomes clinically, but it's also really important for quality improvement. We need to make sure that the mother's pumping behaviors are optimized. And I think, especially because I'm a researcher, that it's most important in research. It increases your rigor of research. So if you have a quality improvement project or an intervention that you're studying, you may have a different outcome if you haven't optimized the same pumping behaviors in all mothers. So if that optimization or that pumping education is different for different mothers, you may have a different outcome, but it may be because the education is different, not that the intervention is different. So standardization is essential. And when we started making and developing these pumping pathways, we wanted to look at two critical time points in those first 14 days postpartum when we were going to do this, quote, optimization, pumping optimization. The first critical window was secretory activation. So it was the time between the mother's delivery and when she attained secretory activation. So during that time, as we talked before, if mothers have a delayed or don't reach secretory activation, they have a much less likelihood of having successful lactation. So we did our first optimization in that time period before secretory activation, usually before the mother went home from the hospital. The second important or critical time period was after the onset of secretory activation until 14 days postpartum. And during that time, mothers really should do something called come to volume. And that is when a mother reaches volumes of at least 500 cc's per day at some point within those first 14 days. And so we did our second optimization after secretory activation, so at about day 6 to day 8. So this is the pumping pathways, and so we have two of them. The first pumping pathway is before secretory activation, and the second one is after secretory activation at around 6 to 8 days of life. And so this is kind of what they look like. So it's about 4 pages, and it really shows you how to teach a mom, how to educate her, and how to optimize her breast pumping journey. And it goes through a number of different elements that each person should check off and go over with the mother. It also has QR codes, and those QR codes are scanned for reinforcement at the time, so the mother can look at it right at that time with the lactation consultant, or she can review it at a different time when she might think about needing more information. And these QR codes are linked to the Provide Compendium, which was created by Dr. Paula Meyer through a grant from the Family Larson Rosenquist Foundation. And everyone has the opportunity to look at that information. And you can see at the bottom of the slide the online address for that. So on the next slide, you can see that this is really the links. And so, for instance, if the mother needed a little bit more information about using the breast pump in a specific way, so providing milk for your infant, getting started, she would be able to read this in-depth information. And also at the bottom of each one of the page was a time for the lactation consultant to put personalized recommendations for that specific mother. So how did we develop these pumping pathways? We started with an integrative review where we went through all the literature and found out what was the evidence regarding optimization of pumping behaviors. We then did our initial draft and had it reviewed by experts in the field. We then pilot tested it and revised it for our final version. And these efforts were really led by one of my PhD students at the University of Florida, Angela Monk, and she really oversaw that pilot testing. And in the pilot testing, we asked about 6 mothers. We went through the pumping pathways with them, and then we really got their feedback on it. What did they think about it? What did they need to change? And some of the things that they said about it was awesome session. Wasn't too long, just enough time to understand everything going on. The actual pumping process helped a lot on cup size, how to let the breast milk flow and when the flow may be done. Another mother said, I think it's a great opportunity, especially for new first-time mothers with little experience. Understanding how much to pump and how to properly use the pump. And so then we said, okay, moms seem like they like it. We have a final version, but maybe it's useless. Maybe we're already doing everything that we're supposed to be doing. Maybe lactation consultants are doing all of this already. So under the leadership in Texas Children of Jessica Gomez, we did this. We looked at lactation consultants and we watched them doing a session of optimization and education with postpartum mothers of infants in the intensive care unit. And we found that we looked to see which one of the pumping pathways section, how much of each of those were covered during their education session. So the section of getting started, only 55% of the elements were covered. Breast setup, 56%. Breast assessment, only 10%. And you can see going down that it really was pretty much 50% or less of the items were covered when lactation consultants did their normal education routine. And we also looked and see how much time it took. And it took about 30 minutes for this optimization and the education to occur. And when we asked lactation consultants what they thought about having some type of a standardized pumping optimization, they said things like, we don't have any way to provide a synopsis of lactation education completed to the pumping mom. Another lactation consultant said an evidence-based checklist would be nice. And 80% would like an evidence-based lactation tool. So it seemed like lactation consultants were really interested in this pumping pathways, and looking at what they were doing, it was needed. So we then decided to see, well, do mothers like it? Is it something that in a large number of moms would they really like? So we took 50 moms and we did a pre-optimization survey. So before they went through the pumping pathways, they did a survey. They then were optimized, and they then did a post-optimization survey. We did that with both the pumping pathways that was done before secretory activation and the second one that was done at about 6 to 8 days postpartum. And we asked mothers to rate how knowledgeable they felt about each topic. So they went from not knowledgeable, which was 1, to very knowledgeable, which was 5. And we also timed it. And that was important to us because one of the things people have been concerned about is that doing the pumping optimization and the pumping pathways would take way too long. And people would not do it because it was so time consuming. But what we found that it wasn't. In fact, it actually took less time to do the pumping pathways than the lactation consultants took when they were doing their own education. And we've just started analyzing this, and so I don't have a lot of information, but what I do have looks very favorable. And this is just the first optimization. We haven't even looked at the second one yet. But you can see the questions. You can also see the first column is pre-optimization. That was what the mothers, how knowledgeable the mothers felt. And the second column is post-optimization. And you can see they looked like they really did feel more knowledgeable about these subjects. And they also had some really nice things to say. They said, I feel way less stress and enjoyed the process. Made me feel encouraged that my body can do this. Less stress because questions were answered and clear. The specifics really painted a picture of what goes into feeding my baby. I feel less stressed and more knowledgeable to be successful in pumping. Her encouragement made me feel excited to continue, and I instantly saw results. And what we're doing now for our final part is seeing, okay, well, everybody loves it. The lactation consultants want it. The mothers love it, but it doesn't actually improve lactation outcomes. So we're currently doing a study where we're taking 100 mother-infant dyads that are involved in a single large study, but 50 of those mothers actually did not have the pumping pathways, and 50 of them underwent pumping pathways. We were matching them for lactation risk, and we're comparing lactation outcomes. So our outcomes include milk volume, duration of lactation, mother's own milk consumption, time to secretory activation, and time to coming to volume. So we'll have that evidence probably maybe in 6 months. But the other thing that I thought, I always put this up as a quote from me. And what I said was, these pumping pathways sure messed up my enrollment. Because what had happened is I'm currently enrolling for a randomized controlled trial. And in that randomized controlled trial, I'm randomizing mothers at risk for poor lactation outcomes. So at risk for not coming to volume. And when I decided to do this, I took all of the hundreds of moms that I had studied in my institution and had a percentage of moms that were going to struggle. And that was what I based the study on. But after I started doing the pumping pathways, that number of mothers that were at risk for not coming to volume and poor lactation outcomes was much smaller. So I keep saying that this is a fantastic tool, but it really is messing up the enrollment in my study. So is it worth it? Is it really sitting down 2 times for 25 minutes to optimize pumping behaviors in moms of preterm and critically ill infants? And I would say yes. I would say it is worth the effort. Pumping for preemies and pumping for critically ill infants, every single ounce that we get from mothers counts in promoting maternal and infant health. Thank you. And we're going to go ahead and transition to the next set of slides, and Trish is going to talk a little bit more about this. But this is such an important topic because we really need to optimize those pumping behaviors to get every single solitary drop of that, what we call liquid gold, in order to be able to provide as much mother's own milk as possible to our vulnerable infants.
Great. Thank you, Leslie. And thank you also to Medela for inviting us again to talk about this work.
I am going to spend the next few minutes talking about the cost savings of mother's own milk feedings. At the beginning of Leslie's talk, she highlighted some of the potentially modifiable complications associated with mother's own milk or mom feedings that I'm going to take a deeper dive into. Here are my disclosures. So to set the stage for the next few minutes, as we think about the economic value of mother's own milk, I want to first highlight the estimated cost savings of reducing potentially modifiable complications, and then help you and NICU leaders more broadly communicate the value of increasing human milk in the neonatal intensive care unit. So you can think about this as helping to communicate the return on investment. And ultimately, the evidence that I'm going to share is all grounded in rigorous scientific studies. Leslie touched on this, but I want to focus on a couple of points. The mother's own milk for very preterm infants has multiple benefits. Premature infants have underdeveloped organs and premature pathways. They're also exposed to a multitude of stimuli in the NICU. Both of these increase the risk for potentially modifiable complications of prematurity. The brain and the lungs are two of the last organs to develop, making them highly susceptible to illness. Mother's own milk or mom protects infants while they're growing. And these complications also have cost consequences. So I'm going to focus on these potentially modifiable complications related to the brain and lungs specifically. So how does mom impact the NICU costs? It reduces the risk of potentially modifiable complications that have both cost to the NICU and lifelong consequences. I'll focus specifically on necrotizing enterocolitis, or NEC, late onset sepsis, and bronchopulmonary dysplasia, or BPD. Mom also reduces the cost of other feedings, including donor human milk and formula, and it reduces the risk of neurodevelopmental problems long-term after the babies are discharged from the NICU. I'm going to highlight briefly the health consequences of NEC, sepsis, and bronchopulmonary dysplasia. First, the health consequences of NEC. The overall incidence in very preterm infants is about 7.6%. There's a very high mortality rate for NEC. You can see on the right-hand side here, when looking at very preterm infants, those without NEC, the mortality rate is about 4.7%. Bell's stage 1 to 3, so including the least severe NEC cases, is about 15%, increases up to more than 1/3 for surgical NEC. It also increases the hospital or NICU length of stay. Without NEC, the average NICU length of stay for very preterm infants is about 59 days. For medically managed NEC, it's about 92, and it increases to, on average, 128 days for surgical NEC. Beyond the NICU hospitalization, there are lifelong consequences: short bowel syndrome, poor growth, and inadequate digestion for surgically managed NEC specifically. These are terrible consequences for the infant and child, and also have consequences for healthcare costs and other costs as well. NEC also increases the risk for neurodevelopmental problems. For late onset sepsis is a bloodstream infection defined as occurring after 72 hours of life. On average, in very preterm infants, the incidence rate is about 8.9%, but it increases dramatically as gestational age at birth decreases. So the average incidence for infants over 29 weeks of gestational age at birth is about 2%, 11% for infants born at 26 to 27 weeks, and then at 23 weeks, it's about 32% incidence. You see a similar pattern for mortality. Comparing infants with and without sepsis, you can see on the bottom right-hand side that the mortality rates are significantly higher for infants with sepsis. Similar to NEC, it also increases the risk for neurodevelopmental problems and other chronic health problems. And then finally, BPD or bronchopulmonary dysplasia. BPD is defined as the need for oxygen at 36 weeks post-menstrual age. There's a very high incidence in infants who are born very low birth weight or very preterm, between 21 and 35%, with an 8% mortality rate. You can see in the bottom right-hand corner, the incidence of NEC increases dramatically with decreasing birth weights. Also, it leads to long-term respiratory problems, reduced lung function, and increased risk for neurodevelopmental problems. So to pull this all together, out of every 100 very preterm infants in the NICU, 7 have NEC, 9 have late onset sepsis, 35 approximately have BPD. And overall, because oftentimes these infants have multiple complications, that 40 or more have at least one of these potentially modifiable complications. Okay, so now let me turn to the evidence about mother's own milk feedings and the implications for these complications. The next few slides are going to highlight research that we and others have done that have specifically looked at the dose and duration of mother's own milk relative to formula and the implications for the incidence of these 3 complications. For NEC, any formula in the first 14 days of life relative to exclusive mom feedings, we found increases the odds of NEC by about 3.5 times. Here on the right-hand side, you can see what this means in terms of the absolute risk of NEC for infants receiving any formula in those first 14 days. On the x-axis in the green, this is the absolute risk of NEC for infants fed exclusive mom. And then on the vertical axis in the blue, this is the absolute risk for infants fed with any formula. You can see it increases dramatically from 3.4% up to 15% for infants who are fed any formula. So focusing on reducing the use of any formula in those first 14 days is critical. Many NICUs now have moved to donor human milk rather than formula, particularly in that early post-birth period. Now let me turn to sepsis. The duration and the exposure period are slightly different for sepsis compared to NEC. In the first 28 days we found of exposure to mom, these are the critical window of time for late onset sepsis. You can see in this figure, the highest line is the highest dose of mom. The middle line is the middle dose of mom, 25 to less than 50 milliliters per kilogram per day of mom in the first 28 days on average. And the lowest line is the lowest dose of mom, or less than 25 milliliters per kilogram per day. So you can see a significant difference in the odds of surviving sepsis-free for these 3 different doses. Now when we turn to bronchopulmonary dysplasia, the key dose and duration are looking at the duration of mom or percentage of mom relative to formula up to 36 weeks gestational age. We found that a 10% increase in mom reduces the odds of BPD by about 9.5%. So on the right-hand side here, you can see how the incidence of BPD decreases as the proportion of mom increases from 30% and higher. Putting all three of these together, you can see that each complication has a different dose and a different exposure period. The first 14 days for necrotizing enterocolitis, the first month for late onset sepsis, up to 36 weeks gestational age for BPD. So different exposure periods and then different doses have been the critical marker associated with increased risk for these complications. Now let me turn to sharing some information about the overall cost of these complications and the cost of a NICU stay overall. First, not surprisingly, prematurity significantly increases healthcare costs in the first 6 months of life. This is a study that looked over the first 6 months, comparing infants by gestational age, full term, late preterm, moderate preterm, and early preterm. For infants born at 31 to 32 weeks gestational age at birth, they estimated that the average healthcare costs were about $100,000, average of 29 days in the NICU. As you go down to 24 weeks gestational age at birth, the average cost in those first 6 months is a multiple of $600,000 per infant, and about 80 days in the NICU. Now, this study was specifically on infants who were commercially insured, so that's important to keep in mind. But these are dramatic healthcare costs in these first few months of life. What about the cost for the NICU hospitalization? This is the estimated cost for a very low birth weight infant throughout that neonatal intensive care unit stay. We estimate that it costs approximately $230,000 on average, and this is the cost to the hospital. Here you can see the different components of what makes up that cost during the NICU stay. Not surprisingly, a good portion, about 74%, is attributed to the length of stay. It's just the daily nursing care for that baby every day for those first 10 weeks. On the far right-hand side, about 8%, 8 to 9% is the physician care. Then you can see in the green, the pharmacy is about 6%, laboratory and pathology is about 3% of those total costs, respiratory about 4%, and so on. So you can see what makes up the overall cost of a NICU hospitalization. So how much do these complications actually cost the hospital? We've estimated that necrotizing enterocolitis increases costs for the NICU stay after controlling for gestational age at birth and other confounding factors, that it costs about $56,000 to treat necrotizing enterocolitis. This is partially due to longer length of stay, but also because of more intensive resource use related to surgery for surgically managed neck, diagnostic testing, pharmacy, and laboratory tests. Late onset sepsis is about $34,000. This is also due to longer length of stay and additional resources, diagnostic testing, pharmacy, and laboratory tests. And then bronchopulmonary dysplasia is about $51,000, also due to additional lengths of stay, respiratory care, pharmacy, diagnostic testing, laboratory and pathology testing. So these are very expensive complications to treat in the NICU. Additionally, I mentioned this earlier in the slides, these often occur together, and having multiple complications further increases the length of stay as well as cost. Here you can see the average length of stay. This was for very low birth weight infants, ranging from about 66 days up to 105, having all three of these complications. Okay, so let's talk a bit about donor human milk. So it's important to think about donor human milk as a bridge to mom feedings versus a substitute for mom feedings. Hospitals acquire donor human milk. So you often will see donor milk as a line item expense in the NICU. That acquisition is a cost to the hospital. Now, in some states, a very small number of states, it is a reimbursable expense. So the cost may be passed on to the payer, but this is a relatively new reimbursable expense, and so this is, I think, new for many hospitals. As we think about the cost per milliliter, it's somewhere between 16 and 20 cents per milliliter, or $4.73 to almost $6 per ounce. How does this translate into the cost for the NICU stay? For an infant fed exclusively donor milk through 34 weeks gestational age, this would cost about $1,500. Now, $1,500, as I showed you in the context of a $230,000 NICU stay, $1,500 is extremely small. However, this is also an expense that the NICU absorbs. As we think about what these costs are and how they accrue to either the NICU or to the hospital. On the left-hand side, I have summarized what a comprehensive lactation support program, the cost to the NICU would be to support mother's own milk. First, the comprehensive lactation support, peer counselors or nurses to provide breastfeeding counseling, hospital-grade breast pumps, pumping supplies, freezer space for the pumped breast milk, waterless warmers and liners. This, we've estimated, costs about $12.35 per 100 milliliters. And this doesn't include the cost to the mother to pump the time she spends pumping her own breast milk and transporting it to the NICU. These are the costs that are borne by the NICU. To support donor human milk, there are some similar costs that the NICU has. In addition to the acquisition cost, the NICU also has the preparation of milk, freezer space, and waterless warmers and liners. We estimate that the average cost per 100 milliliters for donor milk is about $21, so significantly higher. So donor human milk is common in the U.S. NICUs. Here on the left-hand side, you can see a table that summarizes donor human milk use among hospitals with advanced neonatal intensive care units. Approximately 13% of NICUs at this time in 2020 didn't use donor milk at all. That is, they used formula supplementation only. 41.5% of the hospitals that were relatively small, with less than 1,000 total births, didn't use donor milk. So the very small hospitals were less likely to use donor milk. And of NICUs that used donor milk, nearly 2/3 fed donor milk to the majority of infants. So what does that mean for mother's own milk feedings? That means that 20% or fewer of infants received exclusive mom in these hospitals. So there's an opportunity to optimize mother's own milk feedings. And as NICUs think about, well, what is the investment needed to optimize mom? I think this evidence with respect to the cost per milliliter for mother's own milk versus donor milk helps to make that case in terms of what the investment is needed. Okay, so how do we estimate the potential cost savings of mother's own milk in the NICU? We've spent a lot of time with Medela to translate the scientific evidence on the relationships that I've shared with you on mother's own milk feedings and the incidence of necrotizing enterocolitis, sepsis, and bronchopulmonary dysplasia. to translate that scientific evidence into usable data to demonstrate the reduction in the incidence of these complications as mother's own milk feedings increase. So we've translated this evidence into a calculator of sorts that will help NICUs increase mother's own milk feedings. Okay, so in summary, first, reducing the incidence of costly, potentially modifiable complications reduces NICU length of stay, or reduces resource intensity, and decreases costs through mother's own milk feedings. The evidence that I highlighted today is showing the importance of mother's own milk, lack of formula, mother's own milk or donor milk in the first 14 days to prevent NEC, and mother's own milk to prevent sepsis and bronchopulmonary dysplasia. Investments in mom feedings are offset by reductions in the incidence of these complications. Donor human milk as a bridge to mom has a direct cost savings to the NICU. And then finally, we need to translate these scientific research findings into practice. From a research perspective, often we talk about odds ratios and relative risk. And from a practical perspective, we need to be able to take those scientific findings and translate them into measurable data to demonstrate the return on investment. And with that, I will close and open it up for questions.
Excellent. Thank you. And please, everyone, you can continue to submit your questions in our app today. But thank you both, Leslie and Tricia, for your presentation. We have a few questions that have come in so far. And our first one is for you, Leslie. It was talking about in your slides, were the 6 participants that you had all English speaking? And do you know anything about their education level?
So they were all English speaking. We haven't translated the pumping pathways into any other languages, which is something that we want to do when we make sure that it actually works. I don't know their education level. We did collect that information, and we collected that information on the 50 mothers that enjoyed the pumping pathway. So I do have that information, but not at the top of my head. I'm sorry.
It's okay. Thank you. Our second question is, we often see moms that have no recollection of speaking to a lactation consultant, even though we know education was done at least twice following delivery and NICU admission. Do you have any ideas of how we could change this practice?
Well, with these pumping pathways, one of the nice things about this is that we actually give these to the moms. And so we give them those packets. They're about 4 or 5 pages long. And it has everything that we covered, including the QR codes that they can go back and look at more information with that personalized information at the bottom. So yeah, they could lose that information, but we do give it to them.
Excellent. So Tricia, our next one is about the human milk calculator. When you refer to formula, does it also include human milk fortifiers? And when you talked about any formula, does that include breast milk that was fortified?
Yes, great question. When I was referring to formula, it excludes the bovine human milk fortifier. So that that was examined separately. The breast milk fortification, we didn't specifically look at the breast milk or mom fortification. So this was exclusively looking at formula versus breast milk, independent of fortification.
Wonderful. So along that same line, was mother's own milk that was fortified measured in regards to the incidence of NEC?
Another great question. When we did this analysis, we also looked at the relationship of bovine fortification, and we didn't find an independent association with NEC outside of the formula, the dose of formula relationship.
Excellent. So our next question, how much did supply and breastfeeding exclusivity increase with pumping pathways use?
So we haven't looked at that yet. We actually have 50 moms, 100 moms, and we're going to compare 50 that didn't have it and 50 that did. So in 6 months, I will be able to give you the answer to that question. We haven't analyzed it yet. We've collected all the data, but have not analyzed it at all. So stay tuned.
Exciting things coming then.
Definitely.
So the next question is about the pumping pathways and asking for moms that don't have access to Medela Symphony breast pump. Do you know how much of an impact that has on coming to volume if they're using a personal use pump after discharge from the hospital?
Well, one of the things I think is very important is that mothers, that we teach moms and we kind of ask moms about it. There's many different personalized pumps out there. There are many good pumps. There's many pumps that aren't as good. One of the things I think is very important, especially during those first 2 weeks for moms that are pump dependent, is to really advise them not to use wearable breast pumps. Those are really made for working moms for once in a while to add an additional pumping session, but they're not for exclusive use and exclusively pumping mothers. But there's many different types of pumps out there.
Great. All right. I know there were a couple other questions that came in, so let's see here. Are there any recommendations for infants? Oh, I'm sorry, that was the wrong one here. So there's a lot of questions asking about how can others utilize pumping pathways?
Well, that is coming. And so right now they're not for public consumption, but in the next few weeks, I think Medela will be offering them for providers to be able to share with mothers, but they're not available yet. But I think that's coming very soon.
You're right. Yep. So we're excited to continue working with the pumping pathways and have these available for customers. So please stay tuned with us for our launch. And we also want to hear from you. There's a survey question today asking if you'd like to utilize pumping pathways in quality improvement. So be sure to take the survey at the end of our webinar. So it looks like as of now, you've answered all of our questions. We'll wait just a moment or two to see if any more come through. But thank you both for taking time today with us. Anybody have any additional questions?
Well, this was a lot of fun. Thank you very much for having us.
This has been great. Thank you both for being here with us today and for your presentation. And thank you everyone for attending today's webinar, Optimizing Mother's Own Milk Provision in the First 2 Weeks and Its Economic Benefits in the Neonatal Intensive Care Unit. Once we leave today's webinar, you're going to be redirected to a survey like we just talked about today's webinar. And we really appreciate you taking the time to complete it. Your feedback is very valuable to us. You will also receive an email after today's webinar, and that will have a link to view today's webinar recording. And then on behalf of Medela's medical affairs teams and our presenters, we want to thank you again for joining us and have a great rest of your day.
Thank you.
Thank you.